Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Modern Advances in Heart Attack Prevention. It's my pleasure to introduce our speaker, Dr. Rupan Bose. Dr. Bose is a cardiologist and clinical assistant professor of cardiovascular medicine at Stanford. He specializes in preventative cardiology with a particular focus on identifying those high-risk individuals and populations who may be at a higher risk for heart attacks. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Bose will answer as many of those as possible. Over to you, Dr. Bose.
Good evening, everyone. My name is Rupan Bose, and as she said, I'm one of the preventive cardiologists here at Stanford. It's an absolute pleasure to be here with you this evening. Thank you so much for joining us. I'm going to go ahead and share my screen here, and we'll get started with the presentation. So before I get started, again, I really want to just take this opportunity to say thank you. I know it's been a rainy day here in the Bay Area, so I really appreciate you making time to join us here this evening. And I also want to thank the Stanford Health Libraries team for putting together this incredible series of talks and events. So really looking forward to our time together tonight. Tonight, my talk is on modern advances in heart attack prevention. And before we dive into that, what I wanted to start off by talking about is a little bit more about myself and just kind of my background. So I am a local kid from here. I was born and raised right here in the Bay Area in the heart of Silicon Valley and in a Silicon Valley techie family. And I grew up with the hard-held belief and ethos that we all celebrate here, which is we strongly believe that science and technology can give us the power to innovate and to really take on the world's biggest challenges. And as I grew up and I looked around, to me, the biggest challenge that I kept seeing was this concept of heart attacks and cardiovascular disease, because ultimately, we know that cardiovascular disease is the #1 cause of death globally. And for me, looking at that, I was like, this is it. This is what I want to work on. This is what I want to innovate towards. This is what I want to put all my energies to. So that's why I'm really excited and really passionate about being able to be here with you tonight and talk about this. Now, within the realm of cardiovascular disease, there's many different types of cardiovascular disease, but heart attacks probably is one of the biggest categories within cardiovascular disease. See, now this is globally, but here in the United States, it is estimated that there are 805,000 heart attacks in the US per year. That's a big problem. And to put that in context, that's one heart attack every 40 seconds. Now, what's incredible, though, is thanks to so many people, there have been so many incredible innovations that have come up to really turn this around. See, there once was a time in the mid-20th century or so where we thought that heart attacks were untreatable, meaning if somebody had a heart attack, the modern medicine of the day was to say, please take some bed rest, let's ride this out, and let's see how it goes. By the end of the 20th century, though, we had a lot of new advances, and it became to the point where heart attacks were considered to be survivable. But fortunately now, in the 21st century, thanks to so much innovation, we are at the point now where we strongly believe that heart attacks are preventable. And that's what I want to talk about today. So tonight, what I'd like to kind of walk through is let's first talk about what is coronary artery disease. When we talk about heart attacks, that's fundamentally, majority of the time, what we're talking about, this concept of coronary artery disease. Number two, what I want to discuss is how do we identify those people who are at a higher risk for coronary artery disease and a higher risk for heart attacks. Then I want to take some time to dive into uncovering what are the drivers of disease for those people. And then we'll talk about how do we actually define what the targets should be for them and what interventions do we pick to be able to get to those targets. And lastly, we want to design a roadmap for cardiovascular success. What does that look like? So let us dive right in. Let's talk first about coronary artery disease. So as I said, when we talk about heart attacks, what we're really fundamentally talking about is this concept known as coronary artery disease. So if we take a look at this diagram right here, now imagine you're looking at somebody head on. The left side of their body is on the right side of the screen, and the right side of their body is on the left side of the screen. Now let's take a look at their heart. The heart is a giant organ. Its sole job is to pump blood to the rest of the body. Blood carries oxygen, blood carries nutrients. It is the power supply for every other organ and every other muscle out there. Now, as an organ, it is also a muscle, and so it too needs its own power supply. So around the outside of your heart, you have these things called the coronary arteries, which are blood vessels that bring blood to the muscle of the heart in an effort to feed it what it needs and to keep it pumping. Now, there are four major coronary arteries that go around the outside of the heart. 3 on the left side, 1 on the right side. Here, I've highlighted these 4, and what you see, and there are many other branches that come off of it. Really fundamentally, in normal anatomy, there are 4 coronary arteries. Now, on the left side of the heart, there's one called the left main coronary artery, which then splits into 2 more coronary arteries. The first one after that is called the left anterior descending, which is just a fancy way of saying left front going down, and then another one called the left circumflex, which wraps around the left side and into the back. And on the right side, there's just one, just called the right coronary artery. Now, when we look at this and when we think about coronary artery disease, I want to turn to these 2 images from our friends over at the Cleveland Clinic who have drawn what we talk about when we say coronary artery disease, or in fancy terms, atherosclerosis. In more simple terms, it's gunk in the blood vessels. So what we mean by that is this. Over the course of a lifetime, people can develop plaque or atherosclerosis or gunk in these blood vessels. And there's many drivers that causes that to happen. Over time, that can build up, build up, build up. And what's happening is little bit by little, the actual area, the diameter inside the blood vessel that allows blood to flow through, that's getting smaller and smaller and smaller and smaller. Now, at some point, what can happen is if there's any damage to that plaque, the top part breaks and blood actually can touch the plaque. And what happens when blood touches that in this thing called a plaque rupture, a blood clot can form on that area. And now all of a sudden you have another thing that's there sitting on top of this plaque. And that already very small area just got even smaller because now there's another component in there as well. And that ultimately leads to this concept of what is coronary artery disease, wherein if there's so much stuff in there and another thing happens to build up in there, at some point that entire area can get completely blocked off or occluded. Blood can't flow downstream. Blood can't get down to the muscle of the heart. The muscle starves, the muscle dies, and that's what we call is a heart attack. So when we talk about heart attacks, the vast majority of the time, what we're really talking about is this concept here, which is the ultimate buildup of plaque and perhaps a plaque rupture event, such as having a clot get onto it. And then together, the two completely prevents blood from flowing downstream any further and prevents blood from going into the ultimate destination, which is the muscle of the heart. Now, left unchecked, this disease, if we do nothing about it, can just progress over the course of a lifetime and just get build up, build up, build up, build up. But what we know today is that with the science that we have, with the innovation that we have, if we can identify those people early on and we do all the right things, we can flatten that curve. Our goal is to prevent that progression and park that disease where it is. Now, we're also trying to see if there's a way to actually chisel away at the disease that we already have there. And we're still working on the innovation around that. But at least what we can talk about is that we have the ability now to park that disease early on and not let it get any bigger over the course of a lifetime. Now, how do we do that? Now, there is a clinical framework that we think about in an effort to do this. The success of this strategy to flatten that curve relies on these 4 components. Number 1, the key is to identify people early on, people who are going to be high risk or people who are already starting to form disease. And if we can catch them early and we can do all the right things, then we can prevent that disease to progress. Number 2, we want to understand in those individuals, what are the actual drivers that are causing that buildup of disease? What are the things that are progressing that disease or got them to the point that they are today? Then we want to be able to understand that and define what the targets should be. What can we do to actually reverse this course or pause this course? And then what are the interventions that we can do for that in an effort to actually achieve that target? And lastly, we want to be able to measure success and continue to check and iterate and keep working on this plan so that ultimately we can flatten that curve. So again, the framework is this: identify early, understand what's driving this, define targets and intervene, and then measure success and iterate. For those of you from kind of the product world of Silicon Valley, it's develop, it's test, and then it's iterate. Develop, test, iterate, right? So it's understanding what's driving it, understanding how we can measure success, and then continuing to keep evolving on that. Now let's go through each one of these individually. First off, talk about how do we identify those high-risk individuals early on, or how do we identify people who have the beginnings of disease early on? The very first thing that we often lean on are what are called risk calculators. Basically, one of the wonderful things about cardiology is everything that we turn to, everything that we recommend, everything that we have built our field on comes from large clinical trials and large studies over the course of decades. And from that, what we have seen is we've collected so much data that we can basically create these models where we can say that if you have these risk factors and you have this and this and this, and we look back at everybody that we've ever studied before, then you kind of fall into this area, and this is what we predict might be what your future looks like based on where you are today. So those are called risk calculators. One of the most common ones that you'll probably come across is known as the ASCVD risk calculator. This is also known as the atherosclerotic cardiovascular disease risk calculator, which came out in 2013. When you see your primary care doctor, when you see a cardiologist, many of us start off by looking at this because this is probably one of our most validated risk calculators, and we have built a whole framework around this concept. So the goal of this risk calculator is to predict the risk of atherosclerotic cardiovascular disease. Atherosclerotic cardiovascular disease it relates to the diseases that happen from atherosclerosis, meaning plaque, which in the heart means heart attack, and in other parts of the body, let's say in the blood vessels going to the brain, we're talking about the risk of a stroke. So in this calculator, what we can do is we can put in all your numbers and understand what your potential 10-year risk looks like. Also, we can look at what it might look like for your lifetime risk. And then by playing with the calculator, and if we optimize all the different variables, we might be able to tell you what your optimal risk looks like if we were able to break that down and really optimize each one of those individual variables. Now, this is a calculator that's readily available to anybody on the American College of Cardiology website. And again, this is a tool that many of us use in our clinics and most primary care doctors use. So you'll probably interface with it at some point, but yes, you can also look it up at the American College of Cardiology website. And here, we'll go through each of these variables because it tells you exactly what this calculator suggests are going to be the biggest variables to predicting risk, or at least what we thought so in 2013 when this came out. So number one, it looks at your age. Now, typically this calculation can be plugged in for 20 to 79, but usually we use it for 40 onwards. Number two, it looks at your sex, male or female. It looks at race, but it's going to be defined as white, African American, or other. It looks at your blood pressure, systolic blood pressure and diastolic blood pressure. And then it looks at several of the metrics that we often see on your lipid panel, your total cholesterol, your HDL, your LDL cholesterol. Then it looks at whether you've had a history of diabetes in the past, were you ever a smoker in the past? And then it looks at if you've had hypertension or high blood pressure in the past. And then finally, are you currently on some sort of therapy for any of these things, such as a statin for cholesterol or aspirin for antiplatelet properties or anti-blood clot properties? Now, when we plug these numbers in, what we get is a calculation and a predicted risk. Again, this is going to be your 10-year risk. And we put these into a few categories, and we define those people as either being low risk, which is defined as a risk of less than 5% in the next 10 years. A borderline risk, which is going to be defined as 5 to 7.5. And then finally, a 7.5 to 20% is considered intermediate, and anything above 20% is considered high. And what we do next comes very much down to what we see on here and what category one may fall into. And we're going to talk about that a little bit later on as well. Now, As you can see, again, one of the great things about science is that we're constantly learning and we're constantly evolving. And so even this calculator there has been new kind of iterations that have emerged from it over the last couple of years. So in 2023, the American Heart Association put out a new calculator known as the Prevent calculator, which many of you will probably be seeing more and more in the next couple times that you go see a doctor. And what that was designed to do was to further enhance our ability to predict risk by incorporating other metrics and other variables that we also now realize are important into that equation. So we label these as cardiovascular, kidney, and metabolic health metrics. Again, cardiovascular, more related to the heart, kidney for the kidney, and metabolic is kind of your whole body systemic metrics that we want to use in an effort to further hone this risk calculation. This one gives us a 10-year risk and also a 30-year risk. And what it does is actually gives us a few more components. So this one gives us a calculation of your overall risk of cardiovascular disease. It also gives us a breakdown for specifically atherosclerotic cardiovascular disease, which again typically refers to heart attacks and strokes. And then lastly, it also tells us the potential risk of developing heart failure over the course of over the course of these 10 or 30 years. Now, again, this is also readily available, and you can go home and you can plug these in on the American Heart Association's website under the Prevent calculator. And what this does is it looks at a few more categories. Some of these are going to be the same. So we have sex, whether or not you've ever smoked in the past, whether or not you're on some sort of lipid-lowering medication, meaning statins or otherwise. Again, age. So this one now goes down to 30 years. And then also things like HDL. Now, one of the new ones is going to be BMI. BMI is the ratio of your weight to height and gives us a general idea of what is your weight to your frame and how does that look. And that gives us a bit, that can be used as a metric for understanding, do you have a healthy weight to your frame? Additionally, we have here total cholesterol as well as systolic blood pressure. And then we started now incorporating eGFR, GFR being a measurement of your kidney function. So here, right up front, we see that kidney function is going to play a big role in the risk of these three things. We continue with diabetes, high blood pressure medications, and at the very bottom, there's a few other new ones. So you see that there's a urine albumin creatinine ratio, so meaning do you have signs of disease in your urine, suggesting disease from the kidneys? Hemoglobin A1C, which is a measurement of your blood sugar control. And then also in here is zip code, because we know that the socioeconomic determinants of health play a large role in our outcomes. So this is another area that was introduced with the Prevent calculator. Now, these are going to be the two most common risk calculators that we use in cardiology. However, there are many other ones that exist. For example, we'll actually come to that in a little bit, but there are other risk calculators, but these are going to be the two that we are going to use most in how we move forward. Now, the concept of a risk calculator, however, is going to be how one person is compared against a theoretical data set, or I mean a real data set, but how they compare in that data set. And we use that to predict how they might progress over the course of a lifetime. But what we like to believe is that some people don't fit a data set, right? We are our own individuals, and what this feels like sometimes is that this is going to be a little bit hypothetical or theoretical. But sometimes in an effort to be able to move from that to actually understanding if you have any disease today, we move away from risk calculators and we turn to actual imaging. Imaging is another tool that we can use to identify if anybody has any disease already today or doesn't have disease today. And then number two, if they do have disease, to what extent do they have? Is it a low amount? Is it a medium amount? Is it a high amount? We move away from the theoretical risk. We move away from this hypothetical risk of what may happen to you. And we actually can see with a picture and understand, where are you today? Disease or no disease, and to what extent? And there are two different types of tests that we rely on, and both of those are going to be CT scans. Now, why CT scans? So CT scans give us an actual image of the coronary arteries, the blood vessels that bring blood to the muscle of the heart. Oftentimes in the past, we've relied on things like stress tests and perfusion scans, and what that looks at is the downstream impact, meaning that we look at the muscle of the heart, we look at it, whether that's getting blood flow and any changes there, or we look at the electrical signals there with an EKG. When we do stress tests, we're looking at the downstream impact, and from that, what we're doing is we're extrapolating and surmising what may be occurring in the blood vessels of the heart, but it's not a direct necessarily picture of the blood vessels of the heart. CT imaging is a direct picture of the blood vessels around the heart, these coronary arteries. And again, there's two different types. There's going to be a CT calcium score and a CT coronary angiogram. And what I'm going to do is I want to explain the difference between the two. First off, let's talk about what is a CT calcium score. Well, this is a screening test that is a non-contrast based, meaning no dye is injected into your blood vessels. It is a non-contrast CT scan where we look at your heart from top to bottom. And what we're looking for is any type of calcified plaque. What that means is this: when you develop plaque, when you develop atherosclerosis, what you are developing first is this thing called soft plaque. But over time, your body turns that into hard calcified plaque. This hard calcified plaque on our non-contrast study lights up as bright white. So when you look at the left of the screen here, these are some example images of what calcium looks like on a non-contrast study. As you go from top to bottom, what you see is that there's this accumulation of white stuff that occurs in the blood vessels around the heart. That is calcium. That is calcified plaque. So the very first thought here is this: with calcium, what you were looking for is do you have the disease already, or do you have no signs of disease? Now, granted, we can only see calcified plaque. We can't see the soft plaque that requires contrast, which we'll get to. But in calcified plaque, so we can only see that one, but from the amount of calcified plaque that we can see, we can almost kind of predict how much, or what is the likelihood, or how high risk are you to have a lot of soft plaque as well, and therefore put you at risk for developing blockages. We can use this as a screening test because it allows us to guide our next steps, really refine how high risk a person is or is not, really say, do you have any signs of disease or no signs of disease? And from all that information, we can better predict the risk of having an atherosclerotic cardiovascular disease event like a heart attack. Now, I want to turn to this paper because as we now use CT scans more and more, there's been a lot of there's been an effort to try and standardize how we interpret these numbers and what next steps we should take. So I want to turn to this paper here that was written by Dr. David Marin and Dr. Matthew Budoff and their colleagues. And I want to just take a moment to really highlight these two and say thank you, because I was fortunate enough to be able to train under these two doctors. Dr. David Marin is one of the leaders in our field and is one of the leaders here at Stanford in our department. And actually, I believe he actually gave a similar talk a few years ago on this stage right here in the Stanford Health Libraries talk series. And then Dr. Budoff is also another legend in the field. And I've been very fortunate. And I just want to say thanks again to these two individuals for basically, I stand here today because of them and because they lifted me and allowed me to stand on their shoulders and literally stand on the shoulders of giants. So now turning to their paper a little bit, which is to say that what they did was come up with a really elegant framework to explain how we can interpret these scores. So this is perhaps a kind of a complex graphic here, but I really want to just break it into categories. When we do a CT calcium score, we really break it down into buckets. Number one, is there or is there not calcium? Is the calcium score 0? Or is the calcium score something that is not 0? And when we say that there is a calcium score of 0, that means we see no calcified plaque. And even though we cannot see how much soft plaque there is, we can extrapolate from that, from all the clinical trials we've done and with the people we've studied, that people who don't have symptoms, that have a calcium score of 0, the likelihood that they have anything significantly large that would cause a blockage that would lead to a heart attack in the next 5 years is thought to be less than a 1% chance and more like a less than 0.1% chance. So from a calcium score of 0, in a person who is asymptomatic, we are pretty much saying that they pretty much have no signs of disease already. Now, if we then look at anybody who has calcium, meaning a score that is not 0, we break it into a few categories. We look at a calcium score of 1 to 100. We look at a calcium score of 100 to 300. We look at a calcium score of 300 to 1,000, and we look at a calcium score of 1,000 and above. And we say that the calcium score predicts what is the likelihood of having that much more amount of soft plaque as well, and taken together, how much burden of disease, of atherosclerotic plaque disease is there? Is it a mild amount, a moderate amount, a severe amount, or an extensive amount? And based on that, we say, are they relatively lower risk or are they relatively higher risk? And how aggressive should we be in our next set of treatment going forward? So in their framework, what they've proposed is that with a calcium score of 1 to 100, that is a mild amount of disease burden. Yes, there is disease, but there's a mild amount thus far. And we would recommend starting a statin medicine in an effort to stabilize that disease and prevent that from getting any bigger. We recommend having a goal LDL of less than 100, though some people may go even lower. And we want to be able to focus on all the different other drivers that we think are driving their disease forward. A score of 100 to 300 is considered to be a moderate amount. And we're going to do all the same things, but this time we might start talking about adding aspirin. And we'll talk about aspirin a little bit later as well. Now, if his score comes back as 300 to 1,000, we say that's now a severe amount of disease or atherosclerotic burden. And we want to be even more aggressive. We want to go for a high intensity statin, so one of our stronger statin medications. We want to go for an even lower LDL goal of less than 55. And we're really going to consider starting an aspirin medication. Then lastly, a score of 1,000 or more. Now these scores can go up to several thousand. So a score of 1,000 or more, we're going to be talking about using a high intensity statin, going for an LDL goal of less than 55. And then finally, we're going to be talking about whether there's other emerging therapies that are on the horizon that we can use to really try and slow down this disease process. So that's a CT calcium score. I'm going to now switch over to what is called a CT coronary angiogram, which is a little bit different, it is fundamentally still a CT scan. It is fundamentally another CT scan looking around your heart, but where the major difference is going to be is whereas a CT calcium score did not use contrast, did not use dye injected into the blood vessels of the heart, a CT coronary angiogram does use dye or contrast. What we do is we inject contrast into the blood vessels that go then up into your heart, and it basically lights up the inside of your blood vessels. And what we can do is we can actually see all kinds of plaque, actually soft plaque, calcified plaque. And what we can do, because we can actually see it and measure it, we can see how much space does it take up between the one end to the other end of the blood vessel. And we can actually measure the severity of how much it is built up in something what is called stenosis. Now, typically this is reserved for symptomatic patients. However, it can be used for for various cases. But what that information allows us to do as well is that we can do further analytics on it. And there are several emerging techniques that are coming out and being further refined. And those techniques look at plaque analysis or plaque characterization. It looks at plaque volume in total. And then also another concept called CT-FFR, which basically looks at the flow before the area in question, before any kind of what looks like it might be a blockage. We look at the flow before that area, we look at the flow after that area, and we look at the flow difference, the pressure difference between the two, and we look to see, is there a drop-off in that flow from before that blockage to after that blockage, which would suggest that that area is in fact limiting blood flow. And that's the key. What we're really trying to understand is there enough gunk in there that it's limiting blood flow down to the muscle of the heart? So visually, just looking at these two side by side, on the left of the screen here, you have a CT calcium score. Notice it is a little bit darker, and what we see here, the white kind of in the middle of the image. Oh, and sorry, for orientation, what we're looking at is it's as if you are looking at somebody from their feet, and their head is laying down at the back of the screen, and so you're looking from their feet up. The left side of their body is on the right side of the screen. The right side of their body is on the left side of the screen, and then their sternum or their chest is at the top, and their back is on spine is on the bottom. And so in the middle of that heart, what you see there is all that white stuff. That's going to be calcified plaque. This is the non-contrast study, meaning that we can only see calcified plaque. On the CT coronary angiogram, which is the images to your right, that one, notice that the blood vessels are all white, meaning that now this is being lit up by contrast. And what we can see is we can see areas where now, so basically, these blood vessels should look like rivers. They should look like smooth blood vessels going all the way down. For example, in the series of several breakdowns here on the right, you'll see one that says no CAD. Notice that, so that is a picture, that is a blood vessel, and notice that the walls are very smooth all the way down. So that is an area that is a blood vessel that has no signs of atherosclerosis or plaque built up in those areas. The next couple ones are progressively worse and worse and worse and worse. And what you see, if you follow those areas down, you'll see that there's chunks that look like they're the dark chunks that seem to be kind of protruding into the blood vessels. That's the plaque that we're looking out for. That's what we're measuring. We're looking to see how narrow does that area get, which would suggest that there is stenosis or there is blockages. And as the stenosis gets bigger, the probability that one of those areas is going to limit blood flow becomes higher and higher and higher. I want to now move on to another screening test that you may have heard of, and we're seeing more and more of it, which is something called lipoprotein A. Lipoprotein A is another lipid subparticle that works with your other lipids and puts people at a higher risk of developing plaque or atherosclerosis, and ultimately having things like a stroke, a heart attack, more so a heart attack, and calcifications on the blood on the aortic valve, so aortic stenosis. This is considered to be an independent risk factor, an independent causal risk factor for both of these things. Now, what's interesting about it, the reason why lipoprotein A is really interesting is because it is thought to be genetically determined, meaning if it is high for a single individual, it was likely high for the generations before them. It is likely high for multiple first-degree relatives, siblings, children, whatnot. And the higher this number is, the more it puts people at risk for these types of events. So when we hear that there's a long family history of people having cardiovascular events in the family, we start to think, is lipoprotein A one of the culprits in that? So we now recommend doing this as a screening test in an effort to understand if somebody, again, is going to be at a higher risk for any one of these things. Now, to put a little framework around it, there was this paper that came out. So there was the National Association put out a statement back in 2019, which then had an update in May of last year that really tried to define what we should do with this information. Well, first off, the most important thing was to define some sort of cutoffs, meaning that when you now get your lipoprotein A checked, there's two ways that it can be checked, or two units that it can be checked in. One is called nanomoles per liter, and the other unit that it can be done in is milligrams per deciliter. It just depends on which lab you go to. They use different types of ways of measuring this, so it can come in one of those two ways. If you get it tested in nanomoles per liter, then we've defined the cutoff areas to be a low risk is to be under 75. And high risk is considered to be greater than 125, and intermediate is in between. But know that this is on a continuum, and it is thought to be log linear. Again, so the higher this number is, the higher the risk becomes. As a screening test, though, this is a really powerful test. And again, the cutoffs in the other units are going to be 30 milligrams per deciliter and lower is going to be low risk, and then 50 milligrams per deciliter is going to be higher risk. And we're going to talk a little bit more about lipoprotein A in just a little bit. Now, those are going to be some of the screening tests we use to understand if somebody is potentially at a higher risk of developing disease. Now, let's say that we do discover that somebody's at a higher risk, and we've identified that they are high risk or they've already started to develop disease. where do we go from here? Well, what we want to do, what we as preventive cardiologists think about is let's try to dig in and try to understand what is driving that disease. Why are they at a higher risk? What is causing that risk to take off like this? When I think of that algorithmically, the very thing that I think about in that branch point is going to be there's two types of variables. There's two general categories of variables. There's going to be modifiable risk factors, meaning things that are variables that we can actually change, that we can improve, that we can optimize. And then there's going to be non-modifiable risk factors, meaning variables that we can't change, or maybe we don't yet have the science to be able to change, or it's maybe something that we were born with, such as family history. Now, for every one of these non-modifiable risk factors, even if we cannot change those, fear not. What that just tells us is that for the ones that we can change, we're just going to be that much more aggressive about it. We're going to be that much more, we're going to make that much more of an effort to really optimize those other ones, to really try and overcorrect for those non-modifiable risk factors, the ones that we maybe don't, that maybe we can't change just yet. So when we first talk about modifiable risk factors, we think of some of the most traditional risk factors that we've all probably heard of. And recently, the American Heart Association really tried to codify this into something called Life's Essential 8, meaning these are the 8 variables that if we can optimize and really work on, then we really lower our chance of cardiovascular disease over the course of a lifetime. And those are going to be defined by these categories. Number 1, diet. Eating healthy and eating clean is going to be one of the most important things that we can do. In cardiology, one of the best validated diets is going to be what's called a Mediterranean diet, which we can dig into a little bit more later on. The next thing is being more active and exercising. So we say that we ideally would love for people to do moderate level cardio exercise or more, meaning if you're going for a walk, that's fine. A brisk walk if you can, or anything higher than that, whether that's jogging, running, swimming, biking. And we recommend trying to do that for 30 minutes a day, 5 days a week, or in some distribution over the course of the week, but that captures 150 minutes of exercise time. We also want to focus on managing blood sugar and avoiding diabetes. Then we recommend looking at weight and really trying to think back to that BMI. Remember, one of the goals in the US is that the ideal goal to minimize your risk of cardiovascular disease in the US is for a BMI of less than 25. Now, this may be a little bit different in other ethnic groups. For example, we know that people of South Asian heritage and South Asian ancestry are at a higher risk for cardiovascular disease. And one of the things that we have defined as a target for them is actually a BMI goal of less than 23. We also want to talk about controlling your cholesterol, going back to that LDL, and we'll talk about that in a little bit, as well as focusing on blood pressure. And then one of the biggest drivers of cardiovascular disease in the past that we are all trying to make sure to always screen for and make sure we encourage people to quit smoking, because smoking is one of the most well-known risk factors for cardiovascular disease. And with that, we also recommend avoiding other substances as well. Now, and the last one that is often very challenging, especially in a very stressful life or a tough job or something like that, is making sure that you get enough sleep, right? But we do know that that plays a big role in your overall health. Now, beyond that, there are other emerging risk enhancers, meaning we know that these are these traditional ones, but more and more we're starting to uncover these other variables that we know play a role in all this. So one of the other things we talked about a little bit was family history of not just having atherosclerotic cardiovascular disease, but having premature, meaning that men having an event under the age of 55 or women under the age of 65. Another one being if you do everything right, you're doing everything well, but somehow your cholesterol is still just not coming down, your LDL is still above 160, that would be another risk enhancer. Chronic kidney disease, metabolic syndrome, and then we're learning more and more that there are some conditions that occur specifically to women that put women at a higher risk for cardiovascular disease, such as things that are related to pregnancy, for example, such as preeclampsia or gestational diabetes. And then additionally, later in life, the risk of menopause or premature menopause puts us at a higher risk for cardiovascular disease as well. We know that inflammation and other systemic, meaning full body inflammatory conditions play a role, such as things like rheumatoid arthritis, psoriasis, HIV. We also know that, as I alluded to, there are certain ethnic groups that we believe are at a higher risk for cardiovascular disease, including those of us who are from a South Asian ancestry. And then having a persistently elevated triglycerides. We look at CRP being a marker of inflammation, so tying back to these inflammatory conditions, lipoprotein A, which we talked about, apolipoprotein B, and then something called the ankle brachial index, which is just another way of saying, is there plaque in other blood vessels, such as the blood vessels going to your hands and feet? And is there some signs to suggest that there is limited, that something is, that there's plaque built up in those blood vessels that is limiting blood flow to your hands and feet? Now, let's say we identify what some of the drivers are. Well, now we want to focus on that and really define what the ideal target for that should be and start to pick actual interventions to get there. One of the biggest ones we're going to turn to in this framework is going to be your LDL cholesterol, because we literally think that LDL is one of the major building blocks for plaque, for atherosclerosis. And so we set a few different targets. Remember I said that even for as you accumulate other risk factors, we start to set more aggressive and more optimal goals on the other side. Well, we use that same framework here. For everybody, we try to keep a good LDL, a good healthy LDL goal is going to be less than 100. But as you accumulate other risk factors, we start to set lower and lower and lower LDL goals. In some cases where people have other risk factors, we tell them to try and keep their LDL under 70. For example, like we talked about, if the CT calcium score shows that there's some disease already, then we would probably say aim for a goal LDL of less than 70 to flatten that curve. If you have an lipoprotein A, we currently do not have any targeted therapies specifically lowering lipoprotein A. Those are in clinical trials, and we'll talk about that in just a second. But in the interim, what we say is you can overall lower we can try and focus on trying to overall lower your global risk of cardiovascular disease by aiming for a lower LDL goal along the way. In some people, we might even tell them to keep their LDL below 55. This is typically reserved for people who are what we call secondary prevention, meaning that they've already had a heart attack once or they've had some other type of an event, and we now want to make sure that they don't ever have a second one. And so for them, we tell them to try and keep their LDL below 55. And in some cases, we might even be talking about whether it makes sense to try and drive that LDL as low as possible. How do we do that? Well, there's a few different ways we do this. Number one, we're always going to be focusing on good diet, good exercise, and lifestyle changes. But sometimes we have to look towards medications to do this. And we have a large arsenal of things that we can use to be able to do this. So number one, we have statins. We then have other medications like ezetimibe, or also known as Zetia, PCSK9 inhibitors such as Repatha or Praluent, bempedoic acid, inclisiran, and another medication called Vascepa or icosapent ethyl. So that one's typically not for LDL so much, but we use it as a whole for lipid lowering on the triglyceride side. Now, the question becomes, well, how much can we really expect from these medications? Well, the incredible thing is, once we define the target, there's a lot of different ways that we can drive that LDL down with these medications. Now, this graphic comes from the European Society of Cardiology, and what they looked at here is if you use certain medications or combination of medications, what is the expected outcome in terms of how much their LDL drops? If you look here, all the way to the left, statin medicines are quoted around 30 to 50% based on the type of statin or dose. We see a 30 to 50% reduction in LDL. And if you add up all these things in a combination, we can get down to a point where we can drop the LDL down by 86%. So depending on where you're starting from and where your target is, we can bring it down 86% with a combination of all these medications. Now, I said that lipoprotein A currently today does not have any targeted therapies, but fear not, we are in clinical trials right now for multiple different agents right now that all look very promising, and we suspect we'll have one of these to be able to use within the next year or two. I think the estimate is probably around sometime in 2027 that we're hoping that we're going to be able to use one of these. So for right now, we may not be able to lower your lipoprotein A itself. We will focus on using LDL in an effort to lower that, to lower your overall cardiovascular risk. But when these things come out, we're going to be talking about how to lower lipoprotein A itself. The other thing we're always going to be looking for is blood pressure. So We define blood pressure as being normal as less than 120/80. And the most recent guidelines from 2025 suggest that if you have coronary artery disease, or if we're very concerned about trying to keep your disease from progressing any further, the goal is to use medications and treatments and strategies and lifestyle and diet and all these things to try and hit a goal blood pressure of less than 130/80 consistently. And again, normal is considered to be 120/80, so we can even try and go for that, and that's probably going to be even better. But the target right now, per the guidelines, is to drop that blood pressure and keep it down under 130/80. The next one is, there's a lot of questions about these GLP agonists, right? GLP-1 agonists and also these other medications called SGLT2 inhibitors. Now, these are specifically going to be used in the situation of anybody that has coronary artery disease and diabetes. And how do we reduce the risk of those two together from having leading to major adverse cardiac events? There's a guideline recommendation to be able to use these GLP-1 agonists and SGLT2 inhibitor medications in those situations. And lastly, we're also going to be relying on a medication like aspirin or other potential antiplatelet medications in an effort to, if you think back to the diagram we saw, there was plaque and there was these blood clots that can form. The aspirin is designed to help prevent those blood clots. And in the right person, we will talk about whether or not it makes sense to be on an aspirin therapy. It may not be for everybody, because one of the side effects of aspirin is that it may increase one's risk of having bleeding or worsening bleeding if one already has aspirin. So we do want to weigh those risks and benefits and have a meaningful conversation around that. But it may be one of our great tools that we use in our ability to limit the disease progression. So lastly, how do we, so we've figured out what the drivers are, we figured out what we need to do about it, but how do we actually measure success? How do we actually see if we're going in the right direction? And how do we know if we need to iterate or change the plan going forward? Well, this roadmap for success really looks at this checklist. So for anybody that's coming to my clinic and we're talking about how do we prevent disease progression or prevent the onset of disease, in my head, what the checklist that we're going through is, do you have any symptoms? What does your lipid panel look like? How's your LDL doing? What's your glucose status? Are you somebody that's not diabetic? Are you entering the pre-diabetic zone, or are we in the diabetic zone and we need to try and bring that down? How does your kidney function look? How does your blood pressure look? Do we see any signs of plaque in other areas, such as in the hands or feet or in the blood vessels going up to the brain? What's the BMI look? What does your BMI look like? How's your diet? I'm going to ask about what is your activity levels? How much are you exercising? And then I'm going to ask, are you smoking? Or if you used to smoke, have you been able to stop? We're also going to be talking about how are you sleeping? And in the future, we'll probably be talking about lipoprotein A and whether it makes sense to recheck lipoprotein A. We're going to be talking about inflammation and whether it makes sense to check CRPs. And then depending on how all this looks, does it make sense to do imaging or does it make sense to do repeat imaging? Again, so these are the categories that we're thinking through. And if we can define targets for each one of these categories, then that's how we're going to know if we're going down the right direction or not. So turning back to the clinical framework that we set, the goal here is to understand that for those people who are at a higher risk of cardiovascular disease or coronary artery disease, can we catch them early on, either before they develop disease, or if they have developed disease when they're still at these early stages? Can we then dig deep and really understand what is driving their disease? And then can we define what those drivers' targets should look like? And can we come up with interventions to actually do that? And from there, can we keep checking and measuring and making sure that we're staying on track? Because if we can do all these things, then we can fundamentally flatten that curve. We can prevent that disease from progressing over time, and we might even be able to start to chisel away at some of that disease in the future. So putting all that together, if we can do all these things, we strongly believe that we can make heart attacks truly preventable. The key is to do that framework, catch those people early, make those changes, and heart attacks truly can become preventable. These are my references and sources. I want to now say thank you again so much for spending the evening with us and having this conversation. And at this time, I'd like to turn it over for any questions.
Thank you so much. The first question is, do the same strategies apply in preventing additional heart attacks as the first?
Yeah, that's a great question. So high level answer is yes. The difference, though, what's going to be is in the second in preventing the second or future other heart attack. We call that secondary prevention. And what we do there is we're just probably going to be that much more aggressive. So if you think back to that LDL thing that we talked about, one of the targets for primary prevention, meaning preventing that first heart attack, we sometimes will set that LDL goal to less than 70. But when somebody has already had an event, we're going to be even tighter with that goal going forward, such as setting it to be less than 55. In the future, this terminology and framework might even change because we're starting to realize that this is a continuum of disease. And so just because one hasn't had an event yet doesn't necessarily mean they don't have disease, right? So it's the framework will probably shift to being such that we're going to just be aggressive from the get-go as soon as we find any signs of disease going forward.
Thank you. Does being CPR trained help during a heart attack?
Oh, great question. Yes. So CPR training is going to be one of our most powerful tools that we can use as a community to take care of each other. So when somebody has a heart attack, one of the unfortunate outcomes that can happen is when there's no blood flowing to the muscle of the heart, the muscle can basically the heart can go into an abnormal heart rhythm. And these abnormal heart rhythms, such as ventricular tachycardia or ventricular fibrillation, these are what we call non-perfusing rhythms, meaning that the heart muscle actually it doesn't know what to do and it actually doesn't pump blood forward. So no blood is going to any other organ. And so for as long as the heart is in that situation, no blood is going to the brain, no blood is going to anywhere else. When somebody does CPR for that individual, what they are manually doing is actually pumping that heart and sending blood to those areas, sending blood to the brain and sending blood to those other organs. So what we know is when other people do CPR early on for somebody whose heart attack has evolved to the point where their heart is no longer beating, it tremendously increases the chance of survival as well as long-term outcomes in protecting the brain and all the other organs as well.
What is the risk of non-tobacco smoking, such as marijuana?
Yeah, that's a great question. So we are still trying to understand that a little bit more because what we know is this, that smoking, that the concept of smoke and from tobacco use, when you inhale smoke, it causes inflammation in the chest and in the blood vessels around the heart. And that inflammation is what's causing further risk of developing atherosclerosis and plaque. Now, with marijuana, we haven't had an opportunity to study it as much as we've studied tobacco use in the past, but we suspect that some of the same things that we see with tobacco, because of the smoke inhalation component of it, probably holds true for marijuana as well. But we are still running those clinical trials, or we are still trying to really understand that in more detail. So I think we'll see exactly what the outcomes like that for that look like in the future.
When should someone with high blood pressure see a cardiologist?
Yeah, that's a great question. So high blood pressure is one of those things that we talked about is going to be one of the biggest drivers for cardiovascular risk as a whole. Fortunately, it is something that primary care doctors are very well equipped to handle, but certainly if you want to have a conversation around high blood pressure, it is totally appropriate to meet with a cardiologist to see if there's other things that could be driving the high blood pressure underneath it all. And especially if somebody is on multiple different medications or has high blood pressure at a very young age, these would be considered slightly outside of the normal range for blood pressure. Those would all be further reasons to meet with cardiologists to really try and understand, is there some other reason deep down inside that's driving this blood pressure?
Is air quality a risk factor?
Yes, great question. Great question. Absolutely. So we are learning more and more about the role that air quality and environmental toxins play a role in cardiovascular disease. We now understand that in the same way that smoking causes, you inhale smoke and it irritates these blood vessels and it promotes more atherosclerosis and plaque. Air quality is just that as well. So we are still building our framework around that, but it is absolutely known to be true that air quality and cardiovascular outcomes go hand in hand.
What's the latest on the moderate consumption of alcohol, such as a glass of red wine?
Yeah, that's a great question. There's a few different ways that I mean, depending on which study you look at, there's a few different ways that you can kind of interpret this. Fundamentally, what we say is this: all alcohol has the potential to increase your lipids, your LDL, your triglycerides. So fundamentally, all alcohol has the potential to increase your risk of cardiovascular disease. Now, there's some debate about whether certain types of alcohol might actually have other benefits, about tannins and antioxidants and all that. And I would say that the jury's still kind of out on that. But fundamentally, I think if we're worried about somebody who's at a very high risk for cardiovascular disease or is young and starting to already develop it, we're going to probably suggest that trying to keep your alcohol intake as minimal as possible, because every bit does play a role in some of these other risk factors.
How beneficial are omega-3 supplements?
Yeah, great question. So omega-3s are particularly valuable if somebody has high triglycerides. So that is its biggest impact in lowering cardiovascular risk. So if somebody is taking it, it's really for that purpose. But if somebody doesn't really have high triglycerides, then oftentimes dietary omega-3s, like just from eating a well-balanced diet, is probably doing that already. And it may not be necessary to take an additional supplement on top of that.
Could too much exercise be a risk factor?
Great question. So that is actually a very interesting topic, because there is a lot of new data that's coming out that seems a little paradoxical. I'll explain what I mean by that. Recently, there's been some studies that have found that some very high endurance athletes, marathon runners, surprisingly, when we do CT calcium scores for them, some of them have higher calcium scores than other people of similar kind of backgrounds who maybe didn't have that endurance athlete component to it, or the kind of marathon component to it. And that all sounded a little bit confusing, because why would somebody who's exercising more potentially be developing more of this calcifications in the blood vessels around their heart? And so that actually is being investigated further. But we've had many conversations around this within our own department, and where we kind of stand on this right now is that ultimately we still think that the benefits of exercise are fantastic and very high. So it should not be a reason to stop exercising or limiting exercise, but certainly this is a thing to think about as we go forward and try to understand, is there potentially, as you alluded to, is there such thing as potentially having a point where there's too much exercise, and that is there a negative outcome associated with that? Unclear at this time. We would still say continue with exercise, but it's an area that we're all trying to better understand.
What are your thoughts on over-the-counter lipid-lowering therapies?
Yeah, great question. So it really comes down to understanding, I think, what the goal is, which is to say that it really comes down to understanding why are you going after it, and is that going to achieve the goal that you've set? So in these situations, when we're talking about going for these proactive strategies, again, here we're talking about trying to get your LDL down, right? And so we set those. The first is to define the target. Is it 100? Is it 70? Is it 55? And understanding where you are today. And oftentimes, what we're talking about is having to get a big amount of LDL down. Oftentimes, over-the-counter lipid-lowering supplements or medications can have a very small impact in actually lowering LDL, maybe a couple points here and there, at which point it's not quite achieving what you're maybe hoping for, and you're taking more pills than potentially you're really getting benefit from. So at that point, it's really worth having a conversation of, again, what are we trying to achieve? And is that going to be the one that gets us there? Or should we be talking more about potentially some of these other medications that are going to have a much bigger impact? And then the other thing to think about is medications are going to be much more studied and regulated, and there's going to be kind of quality standards around it. Oftentimes, over-the-counter supplements and all that may not have to go through the same level of study or regulation. And because of that, oftentimes the impact of it can be unpredictable and actually can have other negative outcomes that we can't necessarily predict, versus studied medications, which we have a very large database of data behind to back, and we can kind of understand what is going to happen and what are some of the outcomes, the negative outcomes to watch out for, such as side effects.
Thank you so much, Dr. Bose, for sharing all this great information. Thank you to our audience for joining us and for the great questions. If you'd like additional information or resources, please contact Stanford Health Library, and we hope you'll join us for our next lecture. Good night.
Thank you so much.